Hello everyone here. Today we are coming to discuss a new issue, IBD in elderly. This is a new problem which may be faced day after day, and we have steps for the diagnosis and management of a condition like this. Older patient may be having a chronic diarrhea and rectal bleeding and weight loss and abdominal pain, and these symptoms usually may be a suggestive evidence of IBD. If we have a low suspicion of the IBD and a high suspicion for alternative diagnosis, we have to proceed into fecal calprotectin and level of lactoferrin. And we have to evaluate for other causes which must be excluded before diagnosis of the IBD, like microscopic colitis, ischemic colitis, which may be occur in some elderly, especially patients with atherosclerosis and ischemic heart disease, maybe and have ischemic colitis. Segmental colitis, which may be occur with mesenteric vascular occlusion and disturbance in the blood flow in the bowel, and which may be confirmed by CT angiography. Diverticulosis and something like this, or microscopic colitis, which may be diagnosed by endoscopy and biopsy. We have to look for the fecal calprotectin level and lactoferrin and exclude other causes. If fecal level and lactoferrin level are usually within normal, so this is a low suspicion for IBD. Or mild elevation, this is a low suspicion for IBD. We have to proceed to another step of diagnosis. Or if we have a strong or moderate suspicion for IBD in this patient, we have to do colonoscopy and take a biopsy to establish the diagnosis or to exclude other etiological causes. This is from the start for a diagnosis of the IBD. But when we are starting to treat this patient, we have different types of the problem. This patient usually have a malnourished and the malnutritional diseases and the malabsorption and decrease of oral intake and nutritional loss, all of these are major problems in the IBD, which maybe accelerate the IBD and the progress of the disease. Frailty of the patients as weakness and low activity and weight loss, all of these are adding for the progress of the disease. Polypharmacy in some cases, maybe taking non-steroidal and maybe taking oral anticoagulant and other medical treatment for ischemic heart disease and a drug for the CNS. All of these polypharmacy may be a drug-drug interaction and decreasing the efficacy of some of the drugs which maybe can be used in the treatment of the IBD. And this is considered another challenging in the management of the IBD. We have in some cases of the patient, elderly patient, we have a cognitive decline or cognitive disorders and other comorbidity like renal disorders and renal impairment, chronic kidney disease, and something like this. Underrepresented in the clinical trials may be an added problem for these cases. We have no meta-analysis and no guidelines specific for the treatment of this elderly patient and for the progress of it. In this slide, we are coming to concise some of the important issues. If we are decided to start by 5-amino salicylic acid, we have to measure the glomerular filtration rate for this patient and assess the level before starting, as it may be decreased with use of 5-amino salicylic acid. Unable to retain the topical therapy, it is a very common and major problem for this patient. So we have some disorders in the starting the treatment was substitutes. Interaction with Thiopurines may be an adding problem. Thiopurines by self may be an increasing the level of non-Hodgkin lymphoma and non-melanoma skin cancer and drug-drug interaction with Thiopurines like non-steroidal and the ACE and warfarin. All of these are maybe an adding risk factors during the use of Thiopurine. Anti-TNF, which may be exaggerating the effect on the heart and maybe exaggerate the heart failure and decrease the clearance of the kidney, and maybe also contraindicated to be used in the patient with a liver vaccine. It is also one of the major problems. The use of the steroid maybe increase the hip fracture which it is very common problems in elderly patients, and osteoporosis also. Psychiatric disorder with the use of the steroid is very common in especially depression, infection, and glaucoma, and cataract, and something like this may be adding risk in use of the steroid in elderly. All of these issues adding a difficulty in the treatment of the elderly patient and must be considered in the treatment of IBD in elderly. Goodbye.